Wonderful. So as Rob said, I'm Reece Adams, the Senior Clinical Lead of Scope Therapy, Scope Australia. Um, so Scope is a national organisation, Australia's largest disability service provider. Our therapy program is both here in Victoria and in New South Wales. Um, my previous roles have varied across the sector starting off as a disability support worker while studying OT at uni, and have continued to work in various roles. And approximately 6, 7 years ago, began my career in research, looking at wheelchair assessment for complex seating for adults with developmental disabilities, eventually leading to further researching around intellectual disability and healthcare access at the Centre for Developmental Disability Health, and then on to being the head of the Centre for Developmental Disability Health prior to late last year. So my experiences have taught me a lot of the intersection between occupational therapy and the broader health sector, and how we can support people with disabilities, particularly with intellectual disabilities. So what I wanted to talk about today, obviously, is what is occupational therapy, first and foremost. Talking about occupational therapy in the health context, why it's important, the importance of occupation and health in their respective ways, and I guess making this a bit more tangible, how working with an occupational therapist can be improved, or tips and tricks for the future. So what is occupational therapy? Well, it's quite a broad profession. So as I said, I work in the disability sector, but you can work in many different sectors. So occupational therapy, or everything that we do is an occupation. So that can be anything from our personal care tasks to our domestic tasks to our vocational tasks, leisure, etc. So everything that you do that occupies your time is technically an occupation. And we as occupational therapists assist people in different ways, whether they've been injured or they're suffering from an illness, or they have permanent or transient disability. We support people and work with people to have greater independence in their life and in their daily activities, helping them to engage and working with people to engage them in activities. Again, some of it is returning to activities that they typically do. Others might be new activities that they do. And obviously, we're talking about across the lifespan. And providing education and training. So one of the key components of an occupational therapist role is that training and education for supports, or for people themselves with lived experience. The reason why this is so important is that's the sustainability. And unfortunately, whilst occupational therapists try their hardest to guide people through their education and training, it's not always effective without the input and support of others around the individual. Which is why we talk about occupational therapy and its intersection of health. So, generally speaking, without good health, we have poor function, and vice versa. Without good function, we have poor health. Now, that can be in different ways. Obviously, with restriction of activities, we can have poor mental health. But also from restriction of activities or lack of physical daily living activities, we can actually see detriment to physical health and well-being. Occupational therapy, we take very much that intersectional approach. Now, intersectionality, as a modeling, more broadly speaking, some might be familiar with it from the women's health sector, but intersectionality, and those who have recently read the Royal Commission's report, and good on you, it's quite a lengthy report, they talk very much at the beginning around intersectionality and the importance of it. So it's recognizing very much how different factors that are of an individual, so it could be gender, it could be around socioeconomic status, it could be their physical health and well-being, it could be their supports in environments. So we look at it always at an intersectional and how they overlap to enable or, and sometimes at times prevent someone to be able to participate in their daily occupations. And we also recognize that transdisciplinary care is the best approach. So we don't necessarily always see that it works in silo, although obviously there's sometimes where just one particular professional discipline might be required. But often the case is, particularly when we're talking about people with complex disabilities, they often need a multidisciplinary approach, and that's where we look at how we do it in a transdisciplinary approach, using each other's disciplines and skills to share a goal and help an individual to achieve a joint goal often. The particular model that I've included is the PEO model, or the Person Environment Occupation model. It's one of the foundational models of occupational therapy, and it's a very common model that occupational therapists use. The reason that we use the PEO is very much in its breadth of application, really. So when we talk about the person, we're talking about all factors of the person. So it could be their emotional well-being, it could be their physical health, it could be, as I say, their socioeconomic status, it could be their gender, it could be many things. The occupation definitely being what is it that's meaningful to them that they wish to engage in. So it could be those personal tasks, domestic tasks, as I listed earlier, and the many other occupations that might be meaningful in their life, and the environments in which they have to interact with. So the environments obviously can be quite broad in its definition, but typically most people will think of the environments as, a home environment or a school environment or community environments. So when we look at the PEO model, we often look at very much at that intersection. One factor is not always sit in silo. It often may sit in multiple impacts. Which brings me to the International Classification of Function for Disability and Health, which is the World Health Organization's model. It is a gold standard framework. It is a fantastic framework. So it's very much foundational, and it's holistic in its approach. And it's obviously, as I say, intersectional. Now, you'll hear me say intersection a lot because I absolutely appreciate the fact that we do always need to look at it in that way. I think whilst I've described the PEO model, equally with the ICF, within each of these elements, there's broad definition that sits underneath that. But the real important factor here is just how they interrelate with one another. So as we keep moving forward with occupational therapy in its support of people in their daily lives, we often have to sit back and think about what other areas might be impacting on the individual. So bringing occupation health together. So as an occupational therapist who's worked in the disability sector for quite some time now, and having worked with a lot of people with intellectual disability and often communication impairment as well, we sometimes have to use occupation to learn about what might be changes for an individual's health. So you might see, for example, the change in ability. Now that one's usually quite straightforward in the sense that you can physically see it. This particularly relates to people maybe with cerebral palsy, and we might see some changes in spasticity or strength. But equally, sometimes there's undiagnosed genetic disorders that a person may have, and we see the change in their physical ability. It might be unexplained because we don't have a formal diagnosis for it, and that's why it's really important that we get support from other professions to help with that process. We may see the change in task sequencing. So typically we all do things the same way over and over again, how we like to make our toast or how we have our showers and the process in which whether we wash our bodies first or whether we wash our hair first. So we often see a process in a sequence of tasks. Changes in these tasks can sometimes mean changes for the person's well-being. Obviously, with one cohort that we may see more prominence of dementia, so people with Down syndrome, often that will be one of the key indicators where we see changes in their daily activities. Obviously, we know some of those more prominent ages around the 40 to 50 where we see dementia, but as I say, it's not always picked up by the supports that are working with them. So it's important to be conscious of those changes. The apprehension to participate in their daily activities, again, can be indicating of pain or of other areas of concern, so anxiety and other well-being issues. Again, you might see that with the social withdrawal, for example, with both people with Down syndrome, particularly when they have sudden health events, or I guess I said with dementia, you might see social withdrawal. And you might, again, with autism, you might also see people's behavior changes. And again, that's not always indicative of just an outcome of their diagnosis. It could be an underlying issue that's preventing them from wanting to participate. Lastly, the change in support requirements. Now, this one's very tricky because often, particularly with families, they've always supported their loved one. The changes that might happen aren't always picked up. So sometimes that question, the good question around, how do you support the person with their daily life? Has that changed? Is sometimes one of the most important questions we can ask, because we're not, particularly family members, are not always conscious of those changes. So I guess when we talk about working with an occupational therapist, and this is very much applicable to medical and nursing professions, um, I think whilst allied health, we're very understanding of each other's roles and functions, but particularly with medical and nursing, it's often wondering how do we work together, and why would we want to work together, and what might an occupational therapist request from you? So understanding the body and structure. Now, I, as a wheelchair prescriber, um, I often look at hip X-rays. So we're depending on the person's development, and this is a little fun fact, hip dysplasia, depending on their mobility at a younger age, hip dysplasia may become more prevalent as they get older. So obviously very concerning around things like arthritis, and within that hip flexion on their daily function. So if they're hoist transfer using a sling and they go into hip flexion, it'd be quite painful for a person. And again, coming back to some of those things where people start to become hesitant to participate in their daily activities, I have seen it often where people want to rather stay in bed than to move because of those issues. The other part might be around the specialist assessment. So this is where we think about maybe the rehab physicians for spasticity management, or we may need for the prevalence of digestive disorders, gastroenterologists, because we may be concerned about their well-being, especially if they're wheelchair, particularly wheelchair users. If they have impacted bowels and other things, it can be quite uncomfortable and painful for the person in a seated posture all the time. Obviously, the diagnosis needs. So as I said earlier, I have seen people in the past where they've suddenly changed function. Their gait might be altered, or they may have lost strength. And I've had to go back to their GPs and ask for support around diagnosis. One particular case example was where a woman in her 40s suddenly started walking with a lean, and it was assumed that she was developing a scoliosis, but it could be corrected, so it wasn't technically scoliosis. We then asked for a neurology review. The neurologist thought it was just a late onset of cerebral palsy, but it was actually a genetic disorder that this woman had. So then we could actually plan how we're going to support her longer term, because as a result, she had fluctuating functions. So we had to prepare for all circumstances where one day she may not be able to step up into the vehicle, but the next day she may be bounding out the vehicle. So it was very supportive to have the GP. With the health management, occupational therapists are very good at supporting, particularly around those pressure care needs. But incontinence, we can help with the prescription of furniture, bedding, etc. And working with incontinence nurses is always really important in that space, as well as medical, particularly when there might be risk of pressure injuries. Medication support, obviously dosette boxes and those kind of things, but also how a person might be able to take their medication. We can look at alternate methods and ways that people can take their medications. The reviews of the risks, the falls preventions and the pressure injuries, and obviously seeking support for applications. We do need the support of medical diagnoses, particularly when it comes to NDIS. So when we are advocating for the changes of an individual and discussing whether they're permanent, we do need, it's often the case, the support of medical practitioners to list that as a permanent diagnosis. So I guess in moving forward, and I'm conscious of time and apologies, I have to run off soon. But always, I say, work in a human-centered care approach as a group. So when you're working together with occupational therapists or any allied health professional or any sort of care team approach, being human-centered, the person's values, their rights, their interests, what's meaningful, their supports, taking on all of that as you keep moving forward with your approach to care is really, really important. You won't have success in silo, so it's important to always consider the person at the center. MBS items, again, if you're medical, looking at options for MBS items that might help engage a care team arrangement, for example, where you can bill, but it can also provide an opportunity for care team approaches. NDIS funding equally on the other side of it for allied health professionals or those who are NDIS funded. You can often request support, some extra funding if the person's quite complex and you need care team approaches. The communication management is absolutely vital. So in absence of things like shared systems, looking at how if you're working towards a shared goal, how are you going to make sure that you communicate the management of that, how it's going, and obviously the outcomes and sharing that information. And the last part where I talk about leaders and drivers, I think that it's really important. I've been many care team meetings where we're actually not sure who's leading the way. The person that's going to help bring people together and help drive the outcomes for the person. Often, more than not, if it's NDIS, they may have a support coordinator who takes on that central role as the leader and coordinates. Not always the case, and family members are often assumed to do it, or supports are often assumed to do it, and they may not be capable. So it's really important to identify as a care team who could help support, who will lead, and who will continue to bring everyone together to that check-in. Again, it doesn't have to be an assumed role for GPs either, but it's just important to have that discussion open and honest moving forward. So I'll leave it there, but if there are any questions in the Q&A, I can answer those for you now before I run off.
Thanks, Reece. I can't see any questions in the Q&A. I just really like your comments about the communication, because I think that is really important, especially from a general practice point of view. And also, I think people shouldn't be afraid of maybe taking that leadership role if they don't see anyone else doing it and having a discussion, because who is leading it, and don't just assume someone else is. And I think that is really important to work as a team.
Absolutely.
I don't know if we do that well at the moment through lots of different barriers.
I agree. And this is where I think, when we talk about the systems and whatnot, it is very challenging. There are sometimes ways using existing resources. And look, we don't all have the software, particularly with like My Health Records and those kind of avenues where some information be recorded. Occupational therapists don't have access to those systems. So it's really important, whatever the approach is taken, is just very clear and it's documented, and that will help support the care moving forward.
Thanks very much. Look, I know you have to rush off. I really appreciate your time and your insight today for this very important collaboration, really, with Allied Health and for intellectual disability. I know you've been a good friend of the Spider Project over the journey as well, so I really appreciate that.
No,
Thank
it's
you
my
very
pleasure.
much,
It's
Reece.
great work that everyone has done.